Welcome back to Brainista. I'm your host, Adrian, and I'm buzzing with questions today. First, could a single-shot drug replace the standard stroke treatment we've been using for decades, like swapping out a bulky desktop for a sleek tablet? And second, are we on the verge of simplifying stroke care, making it faster and more accessible for everyone, no matter where they are?
Thanks for joining me. Get ready for a whirlwind of insights.
Today, we're exploring a groundbreaking study published in The Lancet in 2022 titled Intravenous Tenecteplase Compared with Altiplase for Acute Ischemic Stroke in Canada, ACT, a pragmatic, multi-center, open-label, registry-linked, randomized, controlled, non-inferiority trial. This paper tackles a crucial question. Can tenecteplase, given as a single shot, be as effective as the current standard of care, altiplase, which requires a bolus followed by an hour-long infusion? The rationale is clear. To see if we can improve stroke treatment by making it faster and simpler, this is huge because time is brain. The study addresses a critical knowledge gap, whether a single bolus tenecteplase can improve reperfusion rates compared to altiplase.
Absolutely, Adrian. The ACT trial was conducted across 22 stroke centers in Canada. They enrolled adults diagnosed with acute ischemic stroke causing neurological deficits, who showed up within 4.5 hours of symptom onset, and who were eligible for thrombolysis under Canadian guidelines. So pretty much anyone who walks in through the door who they would consider for the standard treatment. Exclusion criteria were the standard contraindications for thrombolysis. Essentially, they wanted a broad, real-world patient population. Statistically speaking, the trial aimed to show that tenecteplase was no worse than altiplase, using a non-inferiority design. Clinically, this means that if tenecteplase is at least as good as altiplase, it could become a simpler, faster alternative without compromising patient outcomes.
So,
what did they find? Did this trial actually answer the burning question it set out to explore? It absolutely did, Adrian. The results showed that tenecteplase was indeed non-inferior to altiplase. Think of it like this. Altiplase has been the reigning champion, the gold standard. But tenecteplase proved it could go toe-to-toe and hold its own in the ring. In real numbers, 36.9% of patients in the tenecteplase group had an excellent functional outcome, defined as an MRS score of 0 to 1, compared to 34.8% in the altiplase group.
okay, so they're pretty much neck and neck, but what about safety? Did the new kid on the block cause more harm?
That's the million-dollar question, right? The good news is, no. There were no significant differences in major safety outcomes like symptomatic brain bleeds or mortality. It's like finding out that the new, sleeker sports car is just as safe as the old, reliable sedan. You get all the benefits without the added risk. The trial basically showed us that, yes, tenecteplase appears to be a reasonable alternative to altiplase for all patients who meet standard criteria for thrombolysis.
Okay,
So now that we know what they found, let's get critical. Was their analysis actually cogent? Did they connect the dots in a way that makes sense? Absolutely. Their analysis was pretty solid. The researchers used appropriate statistical methods, clearly defined their outcomes, and were transparent about their analysis. It's like a well-argued legal case. They laid out the evidence and made a compelling argument.
and more importantly, Anna, are the results valid? Can we trust these findings, or is there something fishy going on behind the scenes?
The results appear to be valid. The trial was well-designed, rigorously conducted, and had a large sample size. Plus, the results were consistent across multiple secondary outcomes and subgroups, which adds further confidence. It's like having multiple witnesses corroborate the same story. It makes it much more believable. Now let's dissect the study's strengths and weaknesses. One major strength: its pragmatic design. They mimicked real-world conditions, making the results highly applicable. But the open-label design, where doctors knew which drug patients received, could have introduced bias. It's hard to unsee what you know. The main limitation is that the definition of symptomatic intracerebral hemorrhage that was used in the study may not be uniform and consistent with other trials.
So Anna, what does this all boil down to for the docs and nurses listening? How does this study change what we do on Monday morning?
A great question, Adrian. This research has serious implications for how we approach acute ischemic stroke treatment. Tenecteplase isn't just another drug, it's a potential game changer. It means simpler, potentially faster administration, which can be critical when every second counts.
Faster is always better, but the new drug has to do the job. In the real world, the doctor has to ask, am I helping the patient or hurting the patient?
Exactly. And this study strongly suggests we're helping, not hurting, by streamlining the process and using a drug that's at least as good as what we already have, and in some cases, more practical to administer. That should translate to better outcomes, Adrian. Okay, let's distill this down to brass tacks. Here are 3 actionable points you can take back to your practice. First, consider making tenecteplase your go-to thrombolytic for acute ischemic stroke. Think of it as switching from a multi-step recipe to a one-pot wonder. The ACT trial suggests it's just as effective as alteplase, but way easier to administer. Second, streamline your workflow. The beauty of tenecteplase is that single bolus. It means less monitoring during transfers and imaging. I remember a case where we almost lost critical time fumbling with the alteplase infusion during a code. This simplifies everything. Third, don't just take our word for it. Advocate for integrating tenecteplase into your hospital's guidelines. Be the champion who brings this evidence to your pharmacy and therapeutics committee. It's about being proactive, Adrian. Let's treat more patients and faster. Where do we go from here? What burning questions still need answers? Well, Adrian, I think there's a real need to look at tenecteplase in specific stroke subtypes like cardioembolic strokes. Are there certain patients where it shines even brighter? Also, a cost-effectiveness analysis is crucial. Tenecteplase might be cheaper, but let's quantify those savings. Can we free up resources to improve stroke care elsewhere?
Absolutely. It's like we've opened the door, but there's a whole house to explore. So
You give us something catchy. How are we going to make tenecteplase stick in their brains? How about this, Adrian? Tenecteplase, one and done, stroke treatment redone.
perfect. So let's recap. Tenecteplase stands toe-to-toe with alteplase for stroke treatment, offers a potentially simpler administration, and now we have a talking point. Tenecteplase, one and done, stroke treatment redone.
It's about getting faster, more efficient, and delivering the best possible care when every second counts.
So doctors and nurses, let's start a conversation in your departments. See if tenecteplase can be a game changer at your center.
A huge thanks for sharing your expertise with us today. My pleasure, Adrian. It was great being here.
And that wraps up this episode of At Brainista. Disclaimer and bibliography in the description.